So our topic today is health disparities and the COVID-19 pandemic. And our sort of organizing principle is that pandemics both expose and widen existing health disparities. So, I think we could, our current situation, at least in this country, as three simultaneous and related crises. There's, of course, the pandemic itself, health impacts of that, the sort of follow-on economic devastation that a lot of working families are facing as a result. And then underlying it all is sort of the systemic and institutionalized inequities in society that, have, again, both been exposed and exacerbated by this. So I hope in addition to exploring how those three crises are interrelated, we can also talk a little bit about how we address them. I think it's important, and we're seeing now at this moment in our history how important it is to address them all at once, because you really can't just sort of pull at one strand without impacting the others. So in terms of format, our panelists will make a few brief introductory remarks, just sort of frame the discussion and offer perspective on this from their practices. And then we'll open it up to a further conversation between them and with you. So if you'd like to use the chat function to ask questions, we'll get to as many as we possibly can. So with regard to our panel, I won't take a lot of time to introduce them, but you'll see Dr. Tito Izard as a MD, family medicine physician, and also president and CEO of the Milwaukee Health Services, Inc., which employs more underrepresented and minority practitioners than any other practice in the state. So that's a very important perspective for us to have today. Carolyn McCarthy is an RN and nurse practitioner at Aurora's Walker's Point community. That practice historically has served Spanish-speaking clients, but more recently with the influx of refugee families from Asia and Africa into our community, you now have a much more diverse client base. And first we'll hear from Dr. Loren Galvao, who is an MD and a senior scientist in global health at UWM Center for Global Health Equity in the College of Nursing. She'll be offering a global perspective on this crisis, and she brings to that perspective a wealth of experience, having worked in over 20 countries in Africa, Asia, Latin America, and Europe. So with that, Dr. Galvao, perhaps you'd like to start us off.
Okay, good afternoon, everyone. Thank you for inviting me. It's a real pleasure to be here with all. As you said, in a time of a pandemic, but also with several crises and challenges. And we have all the protests going on against racism across the US and across the globe. So I think it's a wonderful time to have this discussion. So I'd like to start by giving a very brief global perspective and talking about health disparities. Health disparities are a type of difference in health status that are very related to socioeconomic disadvantages. And also from a global perspective, global health is a field of practice, science, and research that aims to achieve health for all and also equity. So this field really looks broadly at beyond borders. We also look at determinants of health, solutions. It's a multidisciplinary field that looks at individual health, but also population health. So health disparities are very important for that. So talking about this pandemic started in China and as an outbreak, and then it spread to several countries, to 188 countries to date. So from China, it went to several countries in Asia and then Europe then to the United States, where we have the epicenter now, and then to Latin America, where Brazil is the epicenter in Latin America, with more numbers confirmed. It's my native country. And then to Africa, where we have a smaller number now. We expect to have an explosion of numbers in Africa. We still don't have, fortunately, and hope we don't. So we have to monitor that situation very closely. To date, we have about 8 million cases, confirmed cases across the globe. And we have several, like almost 500,000 deaths. And the United States is about 1/4 of that. So the United States is really with a lot of cases now and is the epicenter. So just highlighting a few examples of disparities. If you look across the globe and you see several countries, very low income, middle income, and high income countries, we have different health systems. So we have disparities in access to healthcare, and also disparities in the types of healthcare. Like some countries we have universal healthcare, and other countries like ours, we don't. So in some countries we have healthcare as a right, and others we have healthcare as a privilege. For example, if you look at the Democratic Republic of Congo, in terms of spending, they spend about $19 per capita for health. And in high-income countries, we spend about 5,000 or more. The United States is the country where we spend more per capita in the world, 10,000, more than $10,000 per capita. And still we are having the epicenter here. So it doesn't mean sometimes that we spend more, we have the best health system. Another example that I would like to provide is in terms of gender disparities. These are very important. Like according to the UN, 1 in 5 girls below 15 years old, they live in extreme poverty. And this pandemic has really gotten the situation worse because besides the poverty, we are also observing issues of violence against women and girls during this pandemic. So that's another example of disparities. Also, in terms of maternal mortality, that's an area I have been working a lot in global health. We have many disparities across the world. We have the low-income countries are the countries where we have most of the maternal mortality. But if you compare high-income countries among themselves, between themselves, the United States has the highest maternal mortality rates if you compare with high-income countries. And if you look at issues of disparities in this country, if you look at African-American women, they are 3 to 4 times more likely to die due to maternal mortality rate is 3 to 4 times higher than in whites. And with the pandemic, this has actually gotten worse also because we are observing more procedures like C-sections. There has partners cannot actually be with the women or family members. And also in terms of telemedicine, many things are lost sometimes in terms of prenatal care. So we may see, we are observing, there are some reports of things getting worse in maternal mortality and maternal morbidity in the US and across other countries. So now I'd like to touch a little bit on solutions. Like if you look at globally, some of short-term solutions would see like engaging these communities, like minority communities, for example, and really working with them to devise strategies to address health disparities. Also would like to see more advocacy and changes in policies. I think these protests are helping with that, issues regarding racism. Also in minority communities, we should have more like testing and tracing, so more focus on that. health education, and also there is a real need to fund more like community-based organizations and health centers that work at the community level. And in terms of global solutions, I would say more systemic solutions at long run, these solutions I was talking about were more in the short run. But we need also solutions to address this pandemic and racism issues in the long run. So that's not the time to leave global organizations like the WHO. WHO is not perfect, but has been an organization that has been doing a lot of good work globally. So we need more global cooperation, not just with WHO, but with other organizations that also address health equity and issues of racism. In terms of research, it's important to have this global cooperation to develop vaccines, treatment, and conduct more research to research in global health, but also looking at issues of racism and health equity. There is a real importance of improving preparedness. When we had the Ebola epidemic some years ago, there was some improving preparedness for pandemic, but we were not really prepared for this one. So there is a need to improve preparedness, and for that we need global cooperation. Also, it's very important to train the health force. And in terms of academics, there is a real need to develop more courses that focus on global health, pandemics, issues of health equity, and racism. So I would say to students who are listening to this, get curious and explore courses, new courses that are looking into those issues, and even careers, because there is a lot to do. So, and finally, I would like to point out that there is a real need to look at lessons learned about the pandemic and about how to address racism. For example, we have in New Zealand, we have 0 cases now. We have in Germany a very good situation, much better than us here. So we need to learn and look at evidence-based and science. And I would like to close with that, really emphasizing there is a need to look at science, evidence-based interventions that work both for the pandemic of COVID-19, but also for the pandemic of racism. So thank you so much, and I'm open to any questions.
Well, thank you, Dr. Galvao. And Dr. Izard, maybe you can give us a perspective on what you're seeing in your practice based on sort of taking it down from that global view to what it looks like in our community.
Sure. And thank you for inviting me to be a part of this conversation. I'm actually going to put a little twist on hopefully giving a little bit of historical perspective to this conversation, because I think based upon what we just heard and looking at it from that macroscopic perspective and getting a better understanding of kind of why are we here in the situation that we're in, so that we can continue to come forward and make some really good solutions in our everyday life. So I'm going to share my screen here so we can be able to have this discussion. All right. So are you able to see the screen? Share? Okay. So let's talk a little bit about being unstable and how this global pandemic exposed the core issue regarding health disparities in America, and how that impacts my practice as a federally qualified community health center. We care for about 18,000 individuals walk through our door every year. We have about 200 employees, serving 85% of our patients who live at 200%. Well, actually, about 97% of our patients live under 200% of the federal poverty level, 85% of our patients being African American in that respect. When we look at the United States and the original development of our U.S. Constitution, there were 3 core issues that challenged the infrastructure of our system. And that was the issue of slavery, the issue of women's suffrage, as well as the Indian treaties that we had with the Native American population. But as the country developed, the structural racism kind of solidified our US Constitution and allowed now businesses to develop from an institutional perspective based upon those, at that time, Jim Crow laws and other types of rules that allowed some improvement in those three issues, but never truly really resolving them. And as now we moved into the 21st century and we start looking at these issues of white privilege and implicit bias, and that's something I refer to as Black paradox, there's always going to be some level of privilege. And so in and of itself, white privilege isn't a problem. It only becomes because, there's various levels of privilege. Someone may have privilege because they're more attractive, or they may have privilege, because of some other external variable that as an individual, it gives them an advantage over another person. The problem isn't the individual privilege. The problem is the collective privilege. So when we look at data and we say that statistics doesn't apply to you as an individual, but it applies to large groups of people. So when we look at this issue in a macroscopic perspective, and we see that there is something systemically happening that provides that advantage. And then the thing I refer to as Black paradox is throughout our country's histories, there's always been that selection of that top 10% or top 15% of Black Americans who were brought into this America idealism, but they became an overrepresentation. The way the media portrayed them, their role in society really was an overrepresentation of the success and stability of the remainder of the group. So if you happen to be part of that 10% and did well academically, for example, you really did have a lot of opportunities in this country and in your profession. And unfortunately, because of most Americans really don't have any individual exposure to another Black or African American person, the media and the way our perception was that, well, I guess everybody must actually be okay. And reality was just a very small group of people. So what ended up happening is the challenge is, another thing I refer to as malignant indifference, is that we moved away from, again, there's always individuals who exhibit racism, but as a country, we moved away from trying to be deliberately racist and harmful to this position now I refer to as malignant indifferent, which is, if it doesn't impact or affect me and my family, then I'm not really worried about it too much. And what that allowed us to be able to do, looking at the historical perspective from the 18th and 19th century, racism was definitely overt, and it was about harming people. There were laws, it was Jim Crow that was put in place. The 20th century, particularly the second half of the 20th century, the country, agreed, okay, harming people is wrong, so we put rules in place to stop harming, but we never put rules in place to actually help to the level of satisfaction and need, okay? And so when we get now to the 21st century with the malignant indifference, because we never resolved the harm that was created, and we've allowed people, which I say 21st century racism in the form of malignant indifference is actually worse, because a person of moral character in the past would be eventually made aware of their harmful ways was wrong. Okay, it wasn't Christian, it was immoral. But to now allow someone who's malignantly indifferent, that person can say, well, I've never harmed anyone. I've never done anything to Black people or to other people. And it allows them in their own mind to remain conscience free, so that that person, would rationalize and say, I'm a good person and I'm not racist. But that person never contributed to promoting justice, which was definitely needed. So when we look at the issue between the evolution of healthcare, whereas in the 18th and 19th century and even early part of the 20th century it was about health, And then it became about health care, especially as we look at the history of health insurance during World War II, and businesses and companies deciding that they couldn't increase salaries, so they were able to essentially offer benefits. And so that's where the development of employee-sponsored health insurance caused the explosion of health insurance. And so it became an issue of health care. And now what we've seen in the 20th century is the culmination of healthcare practices. So now healthcare at the bottom there as one word is institutional, okay? And the monopolies and all the mergers that are happening between health systems in this country has allowed it to be a very solid institution. But if you look at that image I talked about, what happens when institutions become big without the original addressing of some of those issues of institutional racism? So we have healthcare itself, actually, instead of being an advocate and someone who's fighting for improving health parity or removal of health disparities, it actually becomes a reinforcer of an institution and structure. Okay, so part of this occurred because of the wealth calcification, and it caused a fraction of the American dream. The American dream, really America's dream, was really about hope and about, you know, the opportunity of, through your own hard work and effort, you can actually achieve your goals and dreams. But what happens when you have a significant large percentage of society who had a infraction placed upon them without any restitution, reparations, or resolution? Well, what ends up happening is you have the fraction of that American dream. It creates a cognitive dissonance between, I believe in America and this American dream, but I also see the reality of my life where I'm seeing me and my family and other significant percentages of the Black population not being able to attain this American dream, okay? And so as the wealth calcification occurred, it made it more and more difficult for the Black community to be able to achieve that American dream. So one of the takeaways I want the audience to understand that it's really not your income, it's your wealth position that stabilizes you. And it stabilizes you from these insults of, I call it the homeostatic dimension. So the insults that you may have physical health-wise, your emotional, behavioral health, it may your social, your economic situation, your spiritual. So all of us will experience insults along our lifespan, and it's our stability in our family situation that allows us to weather through. Exactly what's happening right now in the pandemic. Okay, people were able to weather through the stay-at-home order. But what happens when you have multiple areas of these 5 areas that are unstable and you don't have wealth to stabilize you? Well, what ends up happening is instability creates dissociative behaviors, meaning that when you're unstable, you are more likely to make a decision that is inconsistent with your own faith, values, beliefs, and character. We see this happen all the time at all different levels. All human beings do this. But the more unstable you are, the more likely you be able to make some of these decisions. So that's why we see rioting. That's why we see people do behaviors such as pregnancy or some other thing that may be completely opposite of what you wanted for your goals for your life, but you end up doing it because of your overall instability. So this pursuit of being a first-class citizen in America really does look at the expression of the wealth. We see that with the George Floyd situation right now, and as well as the pandemic, the loss of employment, right? If you lose your job, it was your savings that allowed you to make it through if you weren't able to quickly access some of these government resources. Or what happens when unemployment insurance is delayed, right? You're in a pickle, you're in a very difficult situation. So all of these things, your legal rights protections, higher educational attainment, most middle-class families were able to tap into their home equity to help fund their children's education or to have business entrepreneurialism. But if you don't have those things, then it puts you further and further behind. So without wealth, you are unstable. And so looking again at the SARS-CoV-2, the COVID-19 virus and its impact on ADOS, the American descendants of slavery, you look at all these different things listed there, and we'll probably get into them in the discussion, but how the underlying conditions of being Black in America, especially if you have lineage to slavery, you're kind of set up for failure. And then when the pandemic hit, it is no surprise that we're experiencing exactly what we're experiencing. So the bottom line takeaway is that for Native Blacks, health disparities, every single one of them, a previous speaker just talked about infant mortality, for example. These are direct consequences of being an American descendant of slavery. And if there's haven't been a resolution, a comprehensive reparations plan in order to restore people to a whole state, then without that, we're going to continue to have the same challenges. So for our audience, now that we know what we know, how does this influence our thoughts, actions, and behaviors and decisions? We have to stop being malignantly indifferent. And it's not just a message to white community, to white people. This is a message for Black community too, where we all have this level of malignant indifference, where we're not doing what we need to do to promote justice. It's not good enough to say what you're against. So if you ask somebody, are you against racism? Almost everyone says you're against racism. So don't tell me what you're opposed, tell me what you're for. And once we understand what you're for, we have to have that discussion of what are you willing to sacrifice in order to make that dream come true so that we can all become first-class citizens in the United States. Because without it, like Dr. Martin Luther King Jr. says, where do we go from here? Chaos or community? Thank you.
Well, thank you, Dr. Izard. It's very important historical context for our discussion. Well, Carolyn McCarthy, what are you seeing in your practice in terms of how the pandemic is exacerbating these disparities?
I just want to thank both the doctors for what they said today. It's so important, and I just need to hear it over and over again, especially as a person who's born with and skated through life with a great deal of privilege. And I really appreciate the honor of coming here and being with you today. I apologize for my weak internet connection, but I will do my best. So I've been a nurse practitioner for 20 years, and the past 12 I've been working at Walker's Point Community Clinic, which is part of the Advocate Aurora system. And there we serve two populations. We serve people who cannot get insurance, so largely people who are undocumented, and we also serve newly arrived refugees. So when I was thinking today about the factors that influence the racial and ethnic minority health issues that are made more obvious through this crisis, I just want to walk you through my thoughts with a story about a patient. So we're coming down another level from the global and the universal to more of the boots on the ground level here. There are many factors that influence my patients' access to care. So most of patients that I see are both uninsured and undocumented. So I'm going to start with an example there, and I'm going to call her Celia. I had two patients die last week of the COVID illness, and she was one of them. So living conditions definitely influenced her getting the illness and her death from the illness, because she lived in a multi-generational housing situation and was the primary caregiver for her grandchildren. She had people coming and going from her house all the time. Both she and her husband work, and they work in circumstances where they are essential workers. So in addition to that, she has a daughter who is trying to deal with an addiction issue, which is why Celia became the primary caregiver of the grandchildren. So there are a lot of moving pieces in the household, and that's very typical for the patients that I see. They're living in housing situations where they're packed closely together. A lot of times they're older homes that have carved out apartments, or living in a basement or a room that is rented, so they have to interact with other people just to get in and out of the front door. A lot of times transportation is an issue. Patients I work with don't call an ambulance for many reasons. They don't call an ambulance because they are undocumented, and interacting with anybody who's an authority is very scary. This is a population that's very accustomed to moving under the radar. Bus transportation has been difficult, limiting 10 riders per bus, and so when the bus is full, it just passes the stop. It doesn't stop. So a lot of times our patients have to take multiple buses to get places, and that's really hard, and a lot of them don't own cars. I think I can count on one hand the number of times in the past 12 years I've heard of a patient of mine taking an ambulance. It's just unheard of. The other thing that's a complicating factor is the work situation. So a lot of my patients work at Patrick Cudahy or Cargill or other food prep services. They're chopping the fruits and vegetables that you see at the convenience counters in your grocery stores. They're doing a lot of cleaning of grocery stores, cleaning of the meat packing and meat processing plants, because these are the jobs that are available to them. And a lot of them work through agencies, so their work is on a day-to-day basis. One day they might work, one day they might not work, and they have zero job security. So really, in order to eat, they have to work. And I can tell you that the conversations about food insecurity and patients reaching out and asking for food resources has skyrocketed over the past few months. So patients who have to work go to work, and it's very hard to discourage them from working. So we try to come up with some safety plans and safety measures that can help protect them. The next factor that I want to talk about is underlying health conditions. Because a lot of my patients are already ill, it's very hard for them to stay well when they're interacting with other people. So in the Spanish-speaking population, there's a high rate of diabetes and hypertension and other cardiovascular disease. So staying well is very difficult, especially when you're in a tightly packed housing situation, working at a job where you have to work to eat and not having enough space at your job to be spaced out too. I think we all heard the stories about the meat packing plants opening and closing and opening and closing, and that's a lot of patients who I see are working in those meat packing facilities. Going back to transportation and access to healthcare, I want to mention that most patients I work with have a great deal of fear about going to the hospital. The hospital is where people go to die. There's very little trust in the health system. And there are a lot of belief systems that are maybe not in conflict with, but sort of swimming alongside Western healthcare. So there's a lot of different approaches to health, different beliefs about what health is and how we become healthy and how we stay healthy. So going to the hospital or going to the clinic when you're sick doesn't often look like the first solution you would reach for. So I want to just, before I end, just talk a little bit about solutions. So I'll go back to my patient who died last week. And, you know, a solution for her would have been a greater comfort level with the health system. We'd been in touch with her every 2 to 3 days. She'd been tested positive and was calling the clinic, and we were calling her and checking on her symptoms. But this disease is so unpredictable that she got worse very quickly, and she died at home, which is something we've had to really process with the clinic staff because we were so closely in touch with her, and she's been our patient for over a decade. But in thinking about this case, we were trying to come up with some solutions of sort of a street level, how can we make this better and not have this happen again for more of our patients? And so I just wanted to share a few of those thoughts briefly. And I'm not sure they would work universally, but I think that the first one goes back to what Dr. Izard said about race relations and recognizing the provider needs to recognize their own privilege and needs to work hard to balance the power in the room. So when I'm in an interaction, whether it's a phone call, which we're now doing more phone calls and video visits, or whether it's an in-person visit, it's extremely important that I recognize my power in the room to conduct the visit. And it's extremely important that I realize the limitations of what I bring to the interaction. The patient is the expert in their own health. They know their experience, they know what's happening, and they might choose to share or not share things with me. I bring a little bit of expertise. I bring a little piece of the pie to the whole situation. And really, it is an error to think that I should be driving the agenda in the visit. So I think that really embracing cultural humility, doing better listening to our patients to learn about what are the obstacles to care is imperative. So I should have been talking to this patient about her fear of hospitalization, Where does that fear come from? What can I do to make her more comfortable? Can I give her my cell phone number? Can I give her my business cards to take with her to the hospital to show that she's my patient when she shows up there? Can I write her a note that says I need an interpreter? So all of those things are going to be helpful going forward. And I have to say that during this crisis, I've blurred the lines more and more between my private life and my work life. And that doesn't work for everyone. And you know, each healthcare provider has to really make that decision. Who do you share your cell phone with? But I think some of these patients who are at home and are afraid to leave and are afraid to interact with the health system, they really need that extra bridge. They need the bridge of carrying my business card. They might need the bridge of having my cell phone and being able to call me from the emergency room and put me on the phone with the emergency provider, or to be able to call me and say, I think I need to go to the hospital. Will you call the emergency room and, you know, give a report? So I think it's those extra steps that we need to take to again, level the power balance. Because when people are not English speakers, when they're immigrants, when they're undocumented, when they're not white, it's just harder and harder to access care. So I think taking account of who we are as healthcare providers and what we bring to the interaction is of key importance. And looking at the healthcare system as being something that is implicitly biased and serves people who are white and wealthy better than it serves everyone else. And then trying to say, what are the concrete steps that I can take to help my patient who's not white and wealthy get the care they need and live to the fullest?
Very good. Well, thank you so much for that perspective. I will encourage our audience to pose any questions you may have. And as you're doing that, maybe I could start with one. Jump in on this. Please feel free. You know, we've discussed how pandemics really expose those existing disparities in our society, but it shouldn't take a pandemic to do that. So how do we as a society identify and address these things when we're not in the throes of a pandemic? I mean, what are some of the strategies that policymakers and others can use to anticipate those kinds of disparities and address them before we're in a crisis?
I could answer to that. I was talking about preparedness. We need steps to really be prepared as a world, as a globe, and a national, state, and local levels. So we need to plan ahead of time. We know already about these health disparities. We know about racism for a long, long time, several centuries, and it's not being addressed. So I think the pandemic just brought all this, and so now we have to think very carefully to plan if there is any other pandemic. I hope not, but it's really important, as I listen to the colleagues talking about the health disparities, that we plan ahead also. We really use this opportunity to look at what we are doing in terms of everything, in terms of healthcare as a right, also healthcare for all. Like, for example, when we had this pandemic, people needed testing. If we had a system that focused on public health already and community health also, as much as in the tertiary care, we wouldn't have that problem in the United States. So we really need to take steps to be more prepared and to integrate these interventions to fight racism and to fight health disparities and to achieve health equity.
Yeah, and I guess I would comment briefly on that and say, when you're talking about health disparities or working with any vulnerable population, it's important that three critical components are in place. Number one, you have to have, whoever that vulnerable population, they have to have the autonomy and self-determination to select their own leaders, their own representatives. Number two, there needs to be a process for that vulnerable population or group to make sure that there's a certain level of leadership development that will allow long-term sustainability. And the third thing is, so if you're institutions or business, you really have to make sure that there's a certain grassroots capacity building, because the real work with vulnerable population actually happens at the grassroots level. Okay, and so that's kind of the foundation of just starting to build rapport and build credibility and build a relationship. So once you have that, so if you look at the pandemic, there needed to be a coordinated, collaborative and coordinated effort between community, public health, the local municipality government, state, and those four working together would ensure the distribution of federal resources. So the collection, the request, collection and distribution of those federal resources. But we all knew that wasn't in place well before the pandemic hit. So it wasn't a lack of knowledge, it was that lack of awareness. And so those who are surprised that we're in this situation right now, it's more of an educational opportunity for you to say, well, what have you been paying attention to over the last decade or the last whatever number of years you've been in your position? Because everyone at the grassroots level have been saying this, and we all knew about this. And so, and that's the instability I'm talking about. People were making preparations to how do you deal with the chaos and the unstable situation, because we knew resources weren't going to come in the timing that we needed them.
I want to say that I am a true believer that public health and primary care should be unified. I think if primary care and public health were more seamlessly connected, it would be a better health system for everyone. I also think we need to look at who's at the table in the leadership meetings. I think that there need to be more people of color, there need to be more diversity represented in our leadership. And I think that's leadership of our government, of our healthcare organizations. I think that if, I'm a person who's worked with mostly minority people for, more than a decade, and it's not my experience. I discover layers of experience that I don't understand, and I have to be a better listener. And I think that if I were coming out of that community, that I would be a much more naturally empathetic healthcare provider. So I think that starts with education and promotion of opportunities from these communities where people are suffering.
Well, here's a country-specific question to Dr. Galvao. How would you compare the response of the U.S. administration and that of the Brazilian government? And what are the commonalities? How do they differ? And how are the outcomes similar?
I think there are many commonalities because we both, in the U.S. and Brazil, we have right now an administration that is authoritarian, and also an administration that's not focusing on science interventions and is not valuing science. That's what we have in Brazil, for example, with our President Bolsonaro. Unfortunately, Brazil has become the epicenter. But every day I watch the news, I talk with my family, and I see many similarities. Like in Brazil, for example, our president there is not focusing on the staying at home strategies. It was done very late in the process, with exceptions with some states. Actually, the state I come from, Rio Grande do Sul, they start very early, and we have less cases there. But in Brazil, if you compare the north, the northeast, and the areas of São Paulo and Rio, that's where we have more cases. So I think there are many similarities, and it's hard to read every day about, the two countries as I go along. The two countries are the epicenter, the United States now, the epicenter across the globe, and Brazil, the epicenter in Latin America. So we need to follow more the science. Again, I want to emphasize that in both countries. and really implement interventions that are based on evidence. So for me, it's really frustrating to see that, to see my country.
Well, it's an interesting question. If we're hoping for change going forward, a good place to start would seem to be as we're training the next generation of healthcare providers. So what needs to change in terms of how we prepare our healthcare providers?
Yeah, well, one of the things that has to change is from a systems change perspective, so inwardly, is making sure that the students are reflective of the communities that you're going to serve. And despite for several decades now, everyone being aware of that issue and with lip service have said that, but have not really put concrete efforts and actions in place to actually make the outcomes reflect that. And so we've used the excuse that, well, there aren't enough qualified students to be successful. And the reality is that actually is not true at all. There are a significant number of students who would be qualified, and look at on the medical school side, looking at that data. It comes down to understanding that what it takes to be a good doctor is not the same thing as what it takes to score the highest, technical score. And so if we're trying to produce really good doctors who can communicate well with their patients and provide really high quality care, that's what we need to select in our screening process, not the criteria that we've used, which is really old and antiquated.
I also think that we need to integrate to medical schools, nursing schools, and other training programs for the health workforce, integrate explicitly these concepts of racism, health equity, health disparities. I was trained in Brazil as a doctor, and I had a great school there. It's the Federal University of Pelotas, where we had social medicine, and the way I was trained was like really going to communities, and like Dr. Izard was talking about, really important to see the grassroots sides of medicine and nursing. So it's important that we integrate all these concepts more explicitly in the curricula of medical schools, nursing schools, and others.
My 3 years there.
It's an interesting question.
And it's not enough. It perpetuates the, white supremacy that's sort of in the air around us. And I think that it would be very good to have more diverse providers, but it would also be very good to have more diversity in educators.
Well, here's a question going forward. Once a vaccine is developed and we're encouraging people to be vaccinated, how does the health system build credibility within the community?
I would say credibility is developed yesterday, not tomorrow. Okay, so you don't wait until the vaccine or anything that you're trying to deliver, you don't wait till that's out and now you're ready to distribute it. It really has to be, and that's why earlier on when I was talking about forging those relationships, because when you have the integrated conversations between community, public health, health system, the traditional healthcare, and then local and state government, when that infrastructure is already in place, it makes it a lot easier, because the reality is, I don't care who you are and what title you have, at the grassroots level, I talk about instability creates dissociative behaviors. People won't necessarily take the medicine or the vaccine that you're offering, even if it's for their own good, because they won't trust you because of last experiences. The only way to truly get people to buy into something is either you have to have an established relationship where they trust you and you have credibility, or they're going to turn and listen and look at and that's why I say community organizers and community grassroots are so important, because those are the influencers. And if they say no, you can forget it. People are not going to participate to the levels that we need. And so part of the goal is to make sure the community-based organizations, community advocates, grassroots are involved in the creation initially of whatever it is that we need, so that they can give you some insight and say, well, that's not going to work. That message isn't going to work. And then when it's ready to be delivered, when they go out and say, look, I took the shot, I took the vaccination, you should too, then people are more likely to buy into it. Otherwise, for the most part, I would say right now with this vaccination, I don't see anything in place right now that will have the first wave of people getting vaccinated. I know a lot of people will decide they're going to wait at least 6 months before, okay, because we won't trust the system and how it happened.
And I think we also need to learn from the experience with other immunizations that there are already many challenges with childhood immunizations and others. So it's important to look at those experiences that worked to involve people, like Dr. Izard was saying, at the grassroots level and maybe at the other levels also with the media, but based on science. But really learning what worked in terms of involving people and then applying to this new vaccine that hopefully we would have soon next year, sometime next year, hopefully. So it's important to learn also from those lessons.
It's always a struggle day to day to have patients consent to having vaccines. We still have trouble getting the flu shot out, so it's going to be an added challenge.
Well, it looks like we're having some technical issues, but one of the questions I see in the chat room was asking about how you can better provide knowledge to the patients regarding disease, drugs and diseases. And I would say, as someone who's either a practitioner or studying to become some level of caregiver in whatever manner, whenever you're working with clients, you have to make sure that you're able to effectively communicate. Okay, effectively communicate has more to do with the person receiving and understanding than it has to do with anything that you actually said. Okay, and so I like to tell my team, I know what I said, but what did you hear? And it requires the speaker to consciously pay attention and listen to the nonverbal cues that you can get that may show you that the person really is an understanding. If you have someone who's shaking yes through everything that you say, you know that person is just being polite and complicit. And we see that a lot of time with the Latinx community, that respect for elders, respect for healthcare people is extremely important, but it doesn't necessarily mean that they're believing everything that you're saying or that they're going to follow through with everything that you say. So it has to be that relationship, and it has to be spoken in the language that that person can best understand, not just by Spanish versus English. I mean the language that allows that person to receive and understand and interpret it. And so to reflect back, have the person reflect back, okay, I talked about, this medicine, what's your understanding of how you're supposed to use it? What's your understanding of what it's being used for? And the person will be able to tell you in their own words. Whenever someone can tell you in their own words, at least they have the knowledge. Now, you still have to work on the credibility and all the other factors, but at least you have a foundation of knowledge to build from.
But is there a regulatory or governmental solution that you'd like to see? If the White House calls tomorrow and says, what should we do about this? What would your response be?
I would like health care for all in this country. Health as a right. If I could choose one, would be that. And also another one would be addressing specifically, very specific policies that will address these issues of racism, because many of the underlying conditions in these communities, African American, are are due to racism. So that would be one of them. But in general, for everyone, healthcare for all would be something that I would like to see here and in many other countries.
I would ordinarily ask everyone to applaud and acknowledge our wonderful panelists, but we'll just do that virtually. And I'll start with my applause and my thanks to each of you. And be well and wash your hands and wear a mask. Thank you.